Hi, it's Dr. Artie Kavanaugh, RWCS 2019, and we're very pleased to have a number of posters and case presentations and other academic presentations by a really good group of fellows that we're pleased to have with us at the meeting this year. This is Dr. Hanif, who comes to us from Detroit, from Wayne State University, Henry Ford Hospital System. Going to talk to us about a case she has showing the overlap of things we see in rheumatology with some of our other disciplines. Dr. Hanif?
Thank you, Dr. Kavanagh. Very nice meeting you, and I'm having a great time here at Hawaii with the nice weather, which is a shift from the Detroit's weather. So, thank you so much for the invitation. So I'll talk about a fascinating case that I had about scleroderma or malignancy. It was a diagnostic and therapeutic dilemma because the symptoms could be attributed to either malignancy or scleroderma. So it was a veteran, a 61-year-old gentleman who presented with lightheadedness, dysphagia, dinophagia, and his symptoms really started about 1 year ago, and that was a sequela. 1 year ago, going back, he had Raynaud's phenomena, and he noticed the skin thickening diffusely. At the outside hospital, they did a biopsy that showed morphia or localized scleroderma pattern. Of note, his serologies at that time, ANA was 1:640. The typical antibodies that you would expect to see in a scleroderma, the SCL70 and T centromere, were negative. What was positive was RNP polymerase 3. They also did a CT thorax. At that time, they thought it might be a esophageal duplication cyst. They did not progress further, and he was enrolled in one of the scleroderma trials at the Scleroderma Center of Excellence at a university hospital for tocilizumab. So in our hospital, when he presented a year later, he had symptoms of orthostatic hypotension. He was not even able to swallow his saliva. The imaging showed, the CT scan showed diffuse mediastinal hilar lymphadenopathy. Echo was normal. So in our, during the second day of his hospitalization, he had acute respiratory distress, and E-bus was done. And it showed aggressive stage 3 diffuse large B-cell lymphoma, non-Hodgkin's type. Of note, all this happened within a year of his diagnosis. He completed his chemotherapy 4 cycles. He was on EPOC regime. In 5 months, if you notice the difference in the CT scan post-chemotherapy, we can expect the improvement in the mediastinal lymphadenopathy. But what was remarkable was that his skin tightening significantly improved with the administration of chemotherapy within a span of 5 months. So we do know that scleroderma patients have increased risk of cancer compared to general population. That could be because of damage from scleroderma, as in ILD or Barrett's, the cytotoxic therapy that's used for management. It could be an common inciting agent or genetic predisposition. Of note, the recent immune-related adverse effects that we notice, and there is a case of a scleroderma reported from the immune-related adverse effects by the checkpoint inhibitors, such as pembrolizumab. But in our case, it is a unique subset that's been described with concurrent onset of scleroderma and cancer. There's a group led by Shah at Johns Hopkins. He has noticed a striking temporal clustering of cancer diagnosis within a year or within first few years of first signs, clinical signs of scleroderma. In one study, they actually found a 5.08-fold increased risk of cancer within 2 years of scleroderma onset in those with positive RNP polymerase 3 antibodies. So is it the RNP polymerase 3 that should be a red flag for us to search further for any other signs of cancer? Because this study has been replicated in Australia when they noticed at least a 4-fold increase in cancer diagnosis within the first 5 years of signs of scleroderma. So what they hypothesize is the mutated RNA polymerase 3 proteins to be immunogenic that initiate anti-RNA polymerase 3 antibody response. So my conclusion and what the take-home point would be that cancer-induced autoimmunity may occur in a subset of patients with these positive RNP polymerase 3 antibodies We may describe scleroderma as a paraneoplastic disease, and these antibodies should be a red flag that should warrant more aggressive cancer screening. In our case, chemotherapy almost resolved skin tightening. Thank you so much.
Excellent. What an interesting case. Really brings into play a lot of considerations that we have with our patients with scleroderma. I guess, will you follow this patient? Because he may actually be cured if you took care of the cancer, and that was the cause of the scleroderma.
Unfortunately, he passed away last year due to complications of chemotherapy, neutropenic fever, sepsis, septic shock.
Well, that highlights the danger of a very aggressive treatment for scleroderma. Made the skin better, but so it sounds like a bad outcome. But good learning experience. Thank you so much for the presentation, and thank you from RWCS 2019.